Great. So we're going to slowly make a start. I'd like to welcome the presenters and all the attendees today. This is the first webinar in the series, Emerging Early Career Researchers and Practitioners in Human Factors in Healthcare. And the aim of this webinar series is to showcase excellent projects in human factors in healthcare being done by early career researchers and practitioners from around the world. The best presenter out of this webinar series will win the inaugural Richard Cook Prize. So I'm quite excited to be hosting today's session, which is the first in the series, which will have presenters from different countries from around the world. The structure for today's session is we'll have 4 presenters, 1 from South Africa and 3 from the UK. After each presentation, there'll be an opportunity to ask questions. During the presentations, please feel free to post your questions to the Q&A section, which will be monitored, and then these will be put forward to the presenters after their presentation. Great, so I'm honored to welcome our first speaker today, Emma Bell, who is from the Eastern Cape in South Africa. She has recently completed a Master of Science degree at Rhodes University in South Africa and is working at Ergotech in Gauteng as a junior ergonomist. Welcome, Emma.
Thank you very much. I'm going to share my screen. Okay. Can everybody see it? Okay, perfect. Then I'll start. So good afternoon, everybody. As Eva has just said, my name is Emma Bell, and I'm presenting my master's thesis, The Effects of Different Shift Work Patterns on Nurses' Sleep-Wake Behaviors in Selected Private Healthcare Facilities. And I just want to say a special thanks to Dr. Jonathan Davey and Andrew Todd as my supervisors. And so I will just get into it.
Emma.
Sorry, Emma.
So there are a number of challenges to nursing in South Africa.
Emma, so sorry about this. We can't see your presentation.
Sorry?
We cannot see your presentation. Oh, we can see it now. Perfect.
Okay, perfect. Okay. So there are a number of challenges for nursing in South Africa. Firstly, there's a shortage of nurses that are providing care due to an aging nursing workforce and limited nursing education institutions to train and replace the retiring nurses. The shortage requires nurses to work longer hours and more shifts to deal with the quadruple burden of disease, further exacerbated by the social determinants of health. Secondly, there's a maldistribution of resources between the private and public sectors, where the private sector is better resourced, and so the general population then seek medical care from the private facilities. The influx of patients to the private sector puts additional strain on nurses to provide care, as these facilities have to operate beyond their capacity and the nursing shortage. Because human resources are required, the private facilities seek to employ who may match between the public and private sectors or move completely from public to the private, worsening the imbalance of human resources. Since the study took place during the 4th wave of COVID-19, the virus was still unpredictable, and the dynamic nature of the virus placed more stress and increased the existing high workloads on nurses. As a result, the direct patient care and administrative tasks became more fatiguing. Nurses in South Africa work 12-hour shifts, and they often have to work beyond these hours to complete their tasks and hand over to the next shift. Nurses often have to work night shift against their natural circadian rhythms, which negatively affect their sleep-wake behaviors. Private nurses have an unusual rotating shift system where the rotations are unpredictable, affecting the sleep and wake times appropriate for good quality sleep and recovery. These nurses also have to tend to personal responsibilities after work and find it difficult to achieve the work-life balance that favors adequate recovery. Altogether, the shortage of nurses, leading to working longer hours and reduced time for recovery, results in nurses sleeping for less than 6 hours per day on average and results in increased fatigue. Previous literature globally has highlighted the concerns around extended shifts, night work, and rotating shift schedules as a risk to patient and staff safety and well-being. Unfortunately, there's still poor understanding of how nurses' shifts are scheduled in South Africa, particularly in the private sector, and how these shift arrangements impact nurses' sleep-wake behaviors and fatigue. This study therefore aimed to characterize the shift work arrangements and to determine and elucidate the effects of different shift arrangements on nurses' self-reported sleep-wake behaviors and fatigue in selected private healthcare facilities in East London, South Africa. So this study used a cross-sectional survey design, and the tool that was used was the Standard Shift Work Index, a battery of questionnaires used on the premise that shift workers experience disturbances to their sleep, health, and social situations. The original Standard Shift Work Index has 6 sections, but for the purpose of the study, only biographical information, shift details, sleep and fatigue, and the type of person you are or chronotype was included. After obtaining ethical clearance from Rhodes University and the gatekeeper, the study was conducted at 3 different facilities: a hospital, rehabilitation center, and a psychiatric facility. With the help of the relevant unit managers and stakeholders, a combination of convenience, purposive, and snowball sampling was used. The nurses who wanted to participate had to be registered with the South African Nursing Council and had to be working shifts. A pilot study was conducted to test the usability of the amended Standard Shift Work Index, and thereafter changes were implemented for the main data collection that ran over 2 months. Nurses had an option to complete a hard copy or soft copy questionnaire so that nurses from all backgrounds could participate. Thereafter, the data was produced and coded according to the Standard Work Index. Median and quartile ranges were used to describe the data. For inferential statistics, a Kruskal-Wallis and Mann-Whitney-Hughes test was used. And lastly, a thematic analysis was used for the advantages and the disadvantages of the shift system. Half-day, afternoon, and other shifts were excluded as there weren't enough responses for a meaningful interpretation. Out of 300 nurses, a total of 51 nurses completed the questionnaire with a response rate of 17%. They were mostly female, averaging the age of 44 years old. These nurses worked 12-hour shifts, starting or ending at 7 a.m. or 7 p.m. There were 3 distinct groups of nurses: permanent night nurses, rotating nurses, and permanent day nurses. The shift scheduling for the rotating shift system was one of a single night shift, 1 or 2 nights a week, 1 or 2 nights a month, or an occasional block of night shift. What was interesting is that our permanent night nurses worked 7 consecutive nights of shift work with 7 consecutive nights off. Both rotating and permanent day nurses worked up to 5 consecutive shifts with a median of 2.5 days or nights off. Their shift cycle ran over 2 weeks. Because the permanent night nurses work more consecutive shifts, they have a higher number of weekly hours, being 84 hours a week. And we found that they worked more overtime hours than the other 2 groups. This was likely due to handover and increased pay associated with working nights. While nurses stated that they work shifts mostly because it was part of their job and convenient for their responsibilities, more nurses chose to work night shifts because of the higher rates of pay. Our rotating nurses had to change their roster on short notice more than the other 2 groups. This created an unpredictable shift system, meaning that they could not plan around their shifts efficiently. This is a problem for recovery time between shifts, creating shorter, quick returns, which becomes a problem for sleep and fatigue. In this table, our permanent night nurses were sleeping the least of the 3 groups. What was interesting about the sleep durations is that our rotating nurses slept more than the permanent night shift when working nights, and less than the permanent day shift when working days. On the days off, all nurses were sleeping for the recommended 7 to 9 hours or more, and rotating nurses were sleeping significantly more than the day shift nurses. This was attributed to the circadian dyssynchrony that occurs when working day and night shifts alternately in a short period of time, as well as the unpredictable shift system that doesn't allow for adequate sleep and recovery between shifts. As a result, there's an incurred accumulative sleep debt. The shorter sleep duration observed in the previous slide is because permanent night nurses were waking up significantly earlier than the rotating nurses working nights. Permanent night nurses have a predictable shift system and can plan their time for recovery better. permanent night nurses also chose to work night shifts to allow them to plan around their personal responsibilities and also maybe waking up earlier to tend to these responsibilities. While it was not explicitly explored in this study, the speed and direction of the rotation for rotating nurses may have affected their sleep-wake behaviors. With the incurred sleep debt as a result of that unpredictable shift system, there is a greater need for recovery on days off, and thus why rotating nurses were sleeping significantly longer than permanent day nurses on their days off. Regarding the sleep disturbances, our permanent night nurses had the least disturbances, while our rotating shift nurses had the most sleep disturbances. This is because permanent night nurses have predictable shift systems with more consecutive nights and thus able to entrain their circadian rhythms appropriately. Again, the speed and the direction of the rotating shift system may have affected the sleep disturbances for the rotating shift nurses. There were some other interesting non-significant findings. Looking at fatigue, our rotating nurses experienced greater fatigue, with permanent night nurses experiencing the least chronic fatigue. From the literature, it is expected that the permanent night nurses would have higher chronic fatigue scores, but they had the lowest out of the 3. An explanation for this is that there is an association between choosing to work specific shifts and experiencing lesser fatigue, which is the case for our permanent night staff. In addition, in all shift arrangements, nurses had moderate to high workloads attributed to the COVID-19 pandemic, where workloads were high in all wards. Also, the workloads between day and night differ, as there's high workloads during the day due to patients being awake than at night. Together, the greater disturbances, shorter sleep duration on day shifts, and generally high workloads may explain why rotating nurses feel more fatigued. There were no significant differences found between the mediating factors of age, gender, experience, chronotype, and substance use for sleep. But an interesting finding was that there were no evening chronotypes. The literature states that the intermediate chronotype are the most common among nurses, which was the case for this sample. Considering that sleep is a restorative process, the research suggests that sleep loss can have an implication on alertness and performance. With daytime sleepiness, there are decrements in vigilance, alertness, attention, memory, and decision-making, which may result in medical and transcription errors, as well as adverse patient outcomes. For nurses, incidents and errors may be the increased risk of needle stick injuries and post-shift motor vehicle accidents, as they are not able to pay proper attention while driving. In terms of health, circadian misalignment may lead to the increased risk of cardiovascular and gastrointestinal disorders, certain cancers, and reproductive disorders, as the circadian rhythm is linked to the regulation of various hormones. In terms of the limitations, a power analysis was not conducted and has been noted for future research. The data was collected during the COVID-19 pandemic, which may have affected the nurses' willingness to participate outside of their existing workloads. Nurses complained of the length of the questionnaire, despite the researcher having carefully reduced its length. However, various senior nurses mentioned that nurses were exhausted from documenting patient care and thus were tired of writing. The Standard Shift Work Index is a subjective self-report tool, which, while useful, may be affected by recall bias. It obtained acute data, only giving a snapshot into the sleep-wake behaviors and fatigue of the nurses. The speed and direction of rotation was not explicitly explored in this study and is noted for future research, as it may give a better understanding into the sleep-wake behaviors and fatigue of the nurses. I had a relationship with one of the management staff, and this deterred nurses from wanting to participate, as they thought the information will be relayed onto the management. However, the researcher assured them that they would remain anonymous. The quality of the data restricted the use of a multiple logistic regression recommended for the Standard Shift Work Index using Statistica. This played a role in choosing the non-parametric tests such as the Mann-Whitney-Hughes and the Kruskal-Wallis to compare the data. The findings of the study are context-specific and not generalizable, to public healthcare shift nurses in South Africa, or nurses in other private facilities with different shift systems. Sleep-related accidents and incidences, chronic diseases, and individual factors were not explored in this study and has been noted to be done in future research. It is therefore recommended that for the next study, a mixed methods approach be taken, using both objective and subjective measures, also looking at the speed and direction
you have
of the
2
rotation.
minutes.
Thank you. It is recommended to investigate nurses of different wards and specialities, and also to look at the accidents, incidents, and error rates of the nurses. It is also recommended that a longitudinal approach be taken to see a long-term effects on their sleep, wake behaviors, and fatigue. For the institution, it is recommended that they adopt a more predictable shift system using a participatory approach to fatigue management strategies and education programs, as they do not have any fatigue management strategies in place. In conclusion, the aim was to characterize the shift arrangements and subsequently determine and elucidate the effects of shift work on sleep-wake behaviors and fatigue of the private healthcare nurses in South Africa. The overall findings show that nurses are not sleeping enough between their shifts, irrespective of the shift that they are working, and that our permanent night nurses are sleeping the least. The rotating shift nurses experience the most sleep disturbances and fatigue as a result of circadian misalignment, resulting in them having to catch up on sleep on their days off. All in all, shift arrangements do affect the sleep-wake behaviors and fatigue of our South African nurses. Thank you.
Thank you very much, Emma. A very interesting presentation. We have a couple of minutes for questions, so I would ask any of the attendees if they would like to post these in the Q&A. But to start off with, I was wondering, you mentioned a bit about how the workload was the most during the day. Did you at all look at, or was there any hints that there was an overflow of workload from the day shift into the night shift that you were studying?
No, there was no indication. Actually, what the nurses said in passing was that it was better to work the night shift because they had more time, especially to complete their administrative tasks, and that the patients were sleeping at night, so they could be a bit more relaxed. Their workloads weren't as high.
Super, thank you. We have got one question. Please, could you just repeat the name of the questionnaire that you used in your study?
It was the Standard Shift Work Index, so it's by Barton and colleagues in 1995.
Super, thank you. And then also, I was wondering, did you have a look at, was there any difference between a weekday night shift and a weekend night shift or a holiday, sort of those sociocultural influences that might impact workload?
Yes, unfortunately, I did not look at that because at the time it was beyond the scope of my study. But if I do a PhD, which I hopefully will do in the future, I will definitely be looking at more aspects, especially health and the socio-technical aspects.
Super. Thank you very much. Thank you, Emma. And now to our next presenter. We have Natalie Sanford, who is a doctoral researcher at King's College in London, specializing in resilient healthcare and interprofessional teamwork. Her research focuses on understanding the factors that contribute to adaptive capacity in healthcare teams and how healthcare team working is impacted by team structure and context. Natalie has worked clinically in the US with internal medicine and cardiology patients, and has also taught medical, surgical, and high acuity nursing at the University of Maine and King's College, London. Welcome, Natalie. I'm going to hand over to you.
Thank you so much. Let me just share my screen. Okay, can you see that? Okay. Yeah, okay, cool, perfect. Okay, good afternoon, everybody. My name is Natalie Sanford, and I'm delighted to be here to speak with you today about a new method for understanding healthcare pressures and trade-off decisions. To get started today, I'm going to provide some key definitions. Next, I'll introduce the pressures diagram, And finally, I'll share how this tool has been used so far in practice and some ideas for how it could be used moving forward. Although pressure at work is a commonly understood experience, especially since March 2020, for those of us who work in healthcare, it's not often articulated or defined. For the purposes of our research, we define pressure as any aspect of the internal or external organizational context that creates emotional stress, increases the tempo of work, or increases the difficulty of work, thus requiring more mental or physical effort. The picture on this slide is just, for me, the top search result when I type pressure into Google search. But actually, it's really fitting because when you talk to healthcare providers or people in general about the pressure that they're under, they tend to describe this panoply of stressors that impress a feeling of like the walls closing in from all sides. And really central to this experience of pressure is this sense of overwhelm and competing demands. It seems to revolve around this tipping point where pressure has mounted and there's a juncture where something's got to give. And altogether, it's too much to manage, and then a decision has to be made about what to do. Despite that, so far, empirical research to understand pressures in healthcare has generally focused on one or two pressures in isolation. Every day, clinicians balance competing priorities that are often at odds with one another. And in those situations, workers must make difficult decisions about how to manage risk trade-offs so that work goals can still be met. We define a risk trade-off as any decision made during which a decision maker compromises one or more factors when considering two or more desirable but competing factors. Decision makers must consider what outcome to prioritize when it's not possible to maximize all outcomes, and tools to support those sorts of decisions do not yet exist. So what are these competing pressures or forces that complicate work and lead to risk trade-offs? We conducted an ethnography of multiple hospital teams in central London. And from that empirical work and expanding on the work of previous researchers like Rasmussen, we identified 5 pressure categories across multiple system levels: efficiency, organizational, quality and safety, workload, and personal pressures. We identified pressures in our data based on descriptions of the mood of the ward, conversations among staff members about strain, stress, or challenges, observations of tasks being neglected or things not being followed up, and discussions among staff members about trade-offs. Next, we captured these pressures in a visual tool called the pressures diagram. So it's a Venn diagram with one circle for each type of pressure that I listed on the previous slide. The notional operating point, which is indicated by a star, shows which pressures are prioritized by the individual team or organization, and therefore which pressures are traded off. If the operating point falls within the pressures circle of the Venn diagram, that pressure has been prioritized. If the operating point falls within an area of overlap of multiple pressure circles, those multiple pressures have all been prioritized. If the operating point does not fall within a pressure, that pressure has been traded off. To use the diagram to illustrate specific scenarios, pressures can be removed from the diagram if that pressure wasn't present, or shifted in their orientation to one another around the diagram to allow for all combinations of overlap. The zone at the center of the diagram, which is indicated by that small purple circle, is the point where all the pressures overlap. In that zone, all pressures that have arisen are managed to an acceptable level, and no risk trade-offs have taken place. In times of immense pressure, when all 5 pressures are present, this level of performance is conceptualized as being difficult, if not impossible, to achieve. So let's go through some examples from the research to give you a better feel for the diagram. In this scenario that I've captured here, a ward was challenged with really high acuity patients. The number of staff caring for the patients was not sufficient, but additional staff could not be recruited and beds weren't blocked from new admissions, so they were totally full. Those factors created organizational and quality and safety pressures. Due to the increased strain on the team and the pressure to maintain efficiency despite the strain, the ward manager temporarily disregarded their own tasks to help the ward staff by delivering medications for the nurses, checking on patients, doing any monitoring that was going on, cleaning some bays, and delivering meal trays. This meant that the ward work was completed on time, but the manager had to stay late to complete their own outstanding managerial tasks that they had put to one side, and they also didn't take a lunch break. In this case, the manager faced all 5 pressures simultaneously and prioritized 3 of these. Organizational, to keep beds open despite patient acuity and low staffing; efficiency, to keep the ward running efficiently with these challenges; and quality and safety, to ensure that the patients were well cared for despite those resourcing issues. And to accomplish this, they traded off workload by taking on a lot of work and personal pressures in that they took on too much work, didn't have a break, and didn't leave work on time. In another instance, the admitting team faced 4 pressure types during a patient admission. You can see that the diagram looks a little bit different here, and this is because personal pressures weren't present, so I've removed that circle from the diagram. So the diagram now only has 4 pressures instead of 5. In this scenario, a patient needed to be admitted, but there was an organization-wide shortage of beds. The only remaining bed on the ward was a male bed. So a gender breach, which is one of the metrics that we track in the UK and that must be reported by the ward, occurs when a male patient and a female patient are roommates in the same room or bay. However, it's only required that we report that breach if it occurs for longer than 6 hours. So the team was really keen to admit the patient without any delay in their care because they were really sick. So they worked around the mismatch by temporarily admitting the patient to the male bay with the plan to move her as soon as another female bed became available because of a discharge. This created additional work for the staff because the bays had to be cleaned twice and patients were moved around more than they needed to be. But the work was accomplished without overstretching the team. It temporarily impinged on quality and safety metrics, as well as perhaps the patient's experience of care. However, this took place without surpassing the agreed upon acceptable timeframe for the breach and the more pressing quality and safety need of the patient receiving prompt care because they were really sick was achieved for the patient. So while the care delivered wasn't ideal, the operating point falls within that innermost zone anyway. This scenario, like the previous one, only has 4 pressures present. However, unlike the previous example, despite there only being 4 pressures, you can see that that operating point falls outside of the central zone. In this scenario, the consultant or attending physician completed a second daily ward round at 5 p.m. to do a follow-up check on the team's patients for that day. This in turn created more work for the junior doctors who were only rostered till 5:30 p.m., but who typically ended up staying until 7 p.m. or later due to the additional work generated by this second daily round. The culture on this surgical team was to complete those jobs immediately after that second round done by the attending, rather than passing them off to the night team or doing them the next day. They did this in order to maintain efficiency and quality and safety for their patients. In this case, the junior doctors traded off personal and workload pressures to prioritize quality and safety and efficiency. And this is another example in our observations when healthcare workers compromised their personal needs to accommodate other priorities. So just to illustrate some potential uses for the diagram, I've now popped up how that situation might impact the junior doctors the following day. So the patient's care and maybe even discharge have been expedited by the proactive care they received the night before, so it's safe and efficient. And also front-loading the work the night before might have enabled the team to lighten their workload or prepare for the next day. I put this up to show that situations aren't necessarily static in terms of their impact, and the diagram can be used to capture how decisions and pressures impact work over time. Finally, it can also be used to capture multiple perspectives on a scenario. This diagram shows the original scenario the night that it happened from the perspective of the senior doctor, who has a balanced workload, left work on time right after that second round, and facilitated the high quality and efficient care for the patient, balancing all of the pressures that they faced. For better or worse, they did that by delegating to the junior members of the team, but this just illustrates that the same scenario viewed through different lenses can look a little bit different and shows another potential use of the diagram. I've highlighted some of the flexible ways that we've used this method so far, but there are certainly others. I think a strength of the approach is that it isn't prescriptive in terms of its use. In this presentation, I chose to capture specific scenarios, what those scenarios might look like at different moments in time or from different perspectives, and I use narrative summaries to explain the situational context verbally. But alternatively, narratives could be provided in text or could be written in captions or lists within each circle of the Venn diagram. And this flexibility enables individual interpretation and preference and means that the diagram can be used in multiple settings and for multiple purposes, for data collection or for data analysis, or as a conversational tool in practice. I think another strength is that it's easy to use, it has non-technical language, can be used in multiple disciplines, and importantly, the diagram doesn't require that the user appraise the degree to which a pressure was or was not traded off, eliminating the need to measure the location of the operating point. You place the operating point on one of a number of discrete locations or intersections, making it really easy to use. Finally, the pressures diagram is empirically derived and incorporates pressures from all levels of the from the organization. And one of the pressures, personal, is on the micro level. One of the pressures, organizational, is on the macro level, and then the other pressures can flexibly represent any level of the organization, depending on what it is that you're doing with the diagram. Incorporating all system levels in the model more accurately represents complex work than examining a level in isolation, and might also offer some insight into how the levels interact with and impact one another. The focus of this presentation was on introducing the model, but you might be curious about what we've learned about pressures. So just quickly, here are some overall trends from our research so far using this diagram. So healthcare workers prioritize efficiency and organizational pressures when calculating risk trade-offs. Workers sacrifice workload and personal needs to manage these priorities. Quality and safety was also traded off more frequently than efficiency and organizational pressures. And of course, this decision-making culture has long-term implications for the safety and sustainability of the system. Excitingly, this diagram has already been embraced by a couple of other groups of researchers. A group out of the United States used our method in their analysis to understand decisions that nurses made about how to prioritize their task sequencing related to infection prevention. Another group out of Sweden used the diagram to analyze interviews with home care nurses and managers about the pandemic to understand their work demands and trade-off decisions. And based on that, they actually proposed an additional pressure category of socio-emotional pressures, as you can see on their diagram on the right. You could tell that they're engineers, though, because the diagram's been converted to green, brown, and gray. I'm only joking. This was really cool and really exciting for us to see. So moving forward, it would be great to see it used in other settings in healthcare and also in other fields. I'm personally really interested in how pressures evolve over time and the actions that people take to set themselves up for success or to anticipate and compensate early in the shift. I think it could be used as a tool during interviews or by managers to understand team and individual goals and how people view their own decisions. And then, of course, the next step is to think about the impact of these decisions and to develop some decision aids for healthcare workers or workers in general. The work I've been discussing today has been published in Applied Ergonomics. If you don't have access and you'd like a copy, please feel free to email me. Here are references. And you can email me or find me on Twitter, or I don't know, do we call it X now? In any case, please feel free to reach out if you have any questions or if you want to chat further about this work. Thank you so much for the opportunity to present to you today. It's been really enjoyable and I look forward to your questions.
Thank you very much, Natalie. Great presentation, very interesting work. So the first question we have you had any experience using this diagram to have conversation with senior leaders in organizations about how system pressures are impacting staff well-being and care quality?
That's a great question. Not in a research setting yet. I've just completed data collection for a second larger study that is looking at healthcare teamwork in 2 hospitals, one really big hospital and one really small hospital, and then with 5 teams in each hospital that are different based on the work that they do and their structure and design and function. And so as part of that, I am analyzing the data again with the pressures diagram. For that study, I didn't chat specifically in a data collection way with senior managers about how their teams make trade-off decisions. But when I was recruiting people to the study, I, of course, had to tell them a little bit about what I was looking at, and it seemed to really resonate with them. So I would absolutely be interested in doing that in the future. I think what I've found so far in the next sort of branch of this research is that the way that people make those decisions is so different depending on the support they have and the structure of their team. Some teams are more or less supported in taking their break or leaving work on time, depending on the type of work they're doing, which I think is really interesting. So I definitely hope to expand that work, and I think it can definitely be useful for managers, but no, I haven't yet.
Super, thank you. Just building on that, have you also thought of using hospital-wide incidences to test out your tool? Because I think when there's an emergency in the A&E and then they pull resources from other departments, that'll have an impact. And I think your diagram would show managers quite nicely the wider system effects of getting more resources from elsewhere.
Yeah, definitely. I mean, I don't think that this type of work is necessarily linear. Like, you can't always anticipate all of the impacts of a decision that's made, because some of them, it's not always necessarily just positive or a negative or successful or unsuccessful. It's kind of everything at once. And so I think that's something I'm really interested in, is looking at that trajectory, even though it's nonlinear, but trying as best as we can to understand it. So that's something I've done in other projects. But I haven't specifically used this diagram for that yet, but I do think that sort of temporal-spatial aspect is one of the things I'm the most interested in.
Super, thank you. And we have another question from the audience. How do you think you can help develop appropriate adaptive capacity, and how can you prevent adaptation from being the norm?
That's a great question. So my whole PhD, which hopefully I'm submitting in a month, is all about building resilience and adaptive capacity in healthcare teams. So far, I've taken a purely observational approach and just trying to understand how healthcare teams work and what may or may not strengthen adaptive capacity from a structural standpoint in the organization, or on a more sort of meso level. I think that that's sort of the first step to figuring out how to build adaptive capacity, is recognizing that it's not a one-size-fits-all approach. For instance, like an ITU team that has all of the team members co-located in one space, and they work together, they've got long-standing relationships, perhaps better resourced, really specific patient population. Their needs are going to be so different from a surgical ward, where the nurses are, those wards tend to have higher turnover, first of all, but the nurses are co-located, the doctors are off in surgery half the day, the patients on the ward are covered by 8 different medical teams. It's not to say one is better or worse. I just think that their ability to adapt is so different. And I think that's part of the problem with a lot of research into teamwork or building adaptive capacity that's happening at the moment, is it presumes this sort of one-size-fits-all approach. So my objective so far in my research has been understanding work as it happens on the ground and in practice. And then from that, trying to understand, okay, well, what can we do about it? So the next phase is to do a bit of co-design. And now that we've learned about how work happens, think about, well, how can that be improved? And I think that it's probably going to depend on the context, but we can come up with some overarching principles. So I think that's the natural next step. So my answer is I don't have an answer, but it's a great question, and I'm interested in studying that.
Super, thank you. And then, is there anything out there looking into in-hours versus out-of-hours pressures? Did you ever look, or yes?
That's a great question too. So the study that I built the pressures diagram from was all in hours, but the study I just completed, which was 150 hours of observation with 10 different teams in 2 different hospitals, I made sure with the teams that operated out of hours, so the ward team specifically, I made sure to observe at least one either weekend, night, or holiday shift. So that way that would be represented, because a lot of research, especially observational research in healthcare, takes place 9 to 5, which is not the busiest part of the shift and doesn't represent the full spectrum. So I haven't done a comparison, but my next set of data tries to capture both. So it's the whole continuum. A comparison would be really interesting. If anybody wants to take part in doing that with me, I'm keen.
You can contact our team.
Yeah.
Super, thank you. Thank you very much for a very interesting presentation. We're now going to move on to our third presenter for this afternoon, Jill Poots. She is a final year PhD student in the Psychology Applied to Safety and Health Research Group at Leeds Beckett University. Her PhD, in collaboration with a provider of NHS 111, aims to investigate human-system interaction using human factors to improve patient safety outcomes. Her human factors career started at the University of Aberdeen, where she researched non-technical skills and safety culture in agriculture and worked as a human factors intern at Shell. Welcome, Jill, and we look forward to your presentation.
Thanks, Evie. Can you see my screen? I'm not sure which one I'm sharing.
Not yet.
Okay. Looks a little bit different to before. Okay, can you see that?
Yes.
Perfect. A bit bigger. Thank you for the introduction. So yeah, I'm going to sort of give an overview of my PhD research that I've been doing in collaboration with Integrated Care 24 for the last few years, and kind of the highlights of some of the findings. I have attempted to sort of discuss the whole thing, but obviously 15 minutes is not very long, so I'll see how much I get through. So my research focuses on telephone triage. So just to be clear, telephone triage is the assessment of symptoms over the telephone. This obviously happens in multiple settings. In the UK, we have a couple of examples of very large scale telephone triage systems, one being obviously 999, similar to 911 or 112. In other countries, that's the emergency services. In the UK, we also have a 111 less emergency and an integrated urgent care system. So NHS 111 is accessed universally by anyone using a 3-digit telephone number. And this has been described as the front door for a lot of people into the National Health Service. So it's call centre based, unlike other systems around the world. It's mostly front-ended by non-clinical staff known as health advisors, as well as clinical advisors too. And when a patient enters the system, usually they get a disposition at the end, which could range from self-care instructions to an appointment in the primary care system or ambulance response if their presenting symptom escalates throughout the call. So 111 is considered to be quite risk averse, but it has been implicated in serious incidents and harm to patients. There's very little research in telephone triage, especially in primary care, and especially with non-clinical staff front-ending the service. As a result, it relies a lot on technology such as computer decision support, electronic health records and booking, as well as call centre software and technology. Because it's audio only, there's a lack of visual and haptic cues, which means that there's a heightened onus on patients to administer self-tests and also to report their symptoms accurately. So that's the system that I'm investigating for my PhD. So in terms of how I applied human factors to this project, so I really wanted to understand this system as the complex socio-technical system that it is. And to do that, I needed some sort of human factors framework or lens to look at the system and to map it out. So I considered lots of different potential frameworks. We're lucky in human factors that there are lots of different frameworks around, like contributory factors frameworks, for example. And I described it a bit like Goldilocks and the Three Bears, because there was nothing for telephone triage or remote care specifically. And we thought that it would have some latent risks in the system that might not be considered by these frameworks that are often designed using face-to-face hospital settings. So I settled on taking a macroergonomics approach and also embedding the systems engineering initiative for patient safety. That's SEEPS, which is quite a popular tool at the moment in the UK, certainly. So I've used the idea of macroergonomics, so the combination of the micro level, things like technology and individual factors, with the macro level, things like organizational culture and even the external environment, to both design the studies and analyze the results. So I've also been really sensitive to more recent resilience engineering principles. So I am really interested in seeing work as imagined versus work as done, and learning about how organizations adapt and what goes well. So you'll see a lot of that in the slides to come. So just a really brief overview. I'll not talk through the year one, because obviously most PhDs start the same way with literature reviews. I'd say the only different thing was, because it's a truly applied project, working with one organisation, I carried out a familiarisation exercise, which allowed me to see the work that was done, and involved a lot of kind of reading of publicly available information about standard operating procedures, etc. For the bulk of my first study, I used a modified macroergonomic analysis and design approach. So this included a document scan, interviews, and I added on a usability study as well. And most recently, I've been working on a systematic review and best fit framework synthesis, which was then validated by a modified Delphi study to try and develop something that's really specific to the challenges of telephone triage. So the first study was a macroergonomic analysis and design study, as I mentioned, and the whole point of this was, in absence of a lot of research, to try and map the system components, their interactions with one another, and their contributions to patient safety risks. I think secondary to this as well was to validate the use of MEAD. So it's been described as a really promising method, particularly for identifying interactions between system components, but it's not very well utilised at all. So I thought it merited some sort of case study, some sort of application. I'll not talk through the specifics of the questionnaires and the interviews. You can ask me about those if you're interested, but in essence, the modified MEAD framework uses a scanning step. So this was what resulted in from that sort of mapping out the system. I'm not expecting anyone to read that, but mapping out what are the system, the work systems in a circle, and what are the different work processes, who does the work, what's the patient work, what's the patient professional collaboration look like. The second step was to conduct key informant interviews, and I used the critical incident technique to analyse the data using maps, and I used Leximancer as well as reflexive thematic analysis, and then a validation. So to discuss the main findings then, whilst it had been said that there was probably a heightened responsibility on callers who are calling remotely and accessing this healthcare remotely, we were able to typify that and actually sort of look at what the risks were to callers specifically. So things that were mentioned were callers choosing the wrong service. For example, they might call up with very severe chest pain, so maybe something like 999 might be more appropriate than a less urgent call. And then not adhering to worsening advice. So when a patient is in their own home, obviously the onus is then on them to get themselves to where they need to be, assuming they haven't got an emergency ambulance. They might be told to call their doctor within 6 hours. It's up to them to do that, and if they don't take that seriously, that could be a risk. Individual factors relating to risks on the part of staff could be biases, so things like anchoring and confirmation bias, and missing reported symptoms due to fatigue or stress or physical distractions in the call centre. I think it did a really good job of kind of situating NHS 111 and this particular service within a larger system of systems. And there's quite a lot of discussion about demand and availability of other services to pass people on to. Themes relating to system resilience to risk included learning and feedback and clinical support, especially for non-clinical call handlers. So we started to see the things that this sort of unique group of workers, of healthcare workers, needed within this. There were really mixed findings regarding technology usability. So I think this is a lot to do with procedural memory. Obviously, we get used to using technology, even if it's bad technology or even if it's sort of tricky to use. We just don't really know. If I asked you, for example, to tell me how you would send an email from your phone on the Gmail app, you probably could show me, but you might not be able to tell me all of the steps. So for this reason, I decided to do a more objective usability study. So I looked at I used usability heuristics, so heuristic evaluation, and also an observational method to look at workarounds and the workarounds that people do. So I know there's a lot of information on this slide, but I think just to summarise, one of the sort of main heuristic violations that we found with the software was relating to the match between the system and the real world. So the software that was being used and some of the processes in place weren't perhaps representative of how patients, for example, present their problems. So one example is, and this has been commented previously by other authors long before this, that actually healthcare information technology designers assume that interactions between patients and professionals take place in a very linear, reductionist way. So to have to condense symptoms down to one main concern can be quite tricky for people, especially if it's something like a fall where people have lots of different ailments and they have to pick just one to for the purposes of the assessment. So as well as that, I think that was the match between the system and the real world was definitely affected by COVID. So the availability of things like ambulances and GP appointments obviously was much more scarce following COVID. There was more demand and therefore less availability of these things. So dispositions that were on the clinical decision support, for example, relating to less urgent ambulances, were perhaps no longer valid anymore. So you weren't going to get an ambulance necessarily in 3 hours. It might be more like 12 hours, and that led to a lot of workarounds. So we could see as well that the workarounds, some of them were directly related to the technology, and others were affected by organisational pressures and external environmental pressures too. So it was really useful to use this kind of interactionist approach to look at all of the different potential contributory factors. Part of the macroergonomic analysis and design technique is to identify variances. So this is very similar to the work as imagined or work as designed versus the work as done. So I was able to use the data from the interviews and also the data from the document scan to sort of compare how the service is supposed to be run versus sort of workarounds and things like that. So things like national targets came up, so answering calls within 3 minutes. Again, post-COVID, with demand getting much, much greater, that wasn't actually being done through and not because of anyone's fault, just because our world has changed, the external environment has changed. Also conflicting pressures between safety and efficiency. So the allocation of ambulances, there's sort of some decision making involved and maybe getting alternative solutions for certain patients, and things like I've already mentioned the patients reporting their symptoms and reporting maybe like 3 or 4 symptoms, but the technology wants them to report 1. And the validation steps that I used in addition to my own secondary analysis was a focus group and a survey, and after six months after data collection there was good agreement. I'm just going to quickly talk about the modified Delphi study and the systematic review, because I think it's really a good springboard to discuss future directions. So I carried out a systematic review and best fit framework synthesis, again using SEEPS 2.0. And as you can see, most of the papers and most of the codes generated from those papers referred to the patient factors that might influence safety in telephone triage. And there is very little on the physical environment, for example. So I think that's a really useful place to go next. There's really high agreement with the Delphi panel. So a panel of 23 participants from the organisation I'm working with, and from academia and from other organisations as well who do telephone triage. And I had really high agreement. 180 different factors were agreed upon. So obviously that wasn't very user friendly. So we've got them condensed down through a process of reflexive thematic analysis. So you can see that things like, for example, the tools and technology, issues, potential contributory factors to risk include the design of technology, as I found in my first study too, and also using and interacting with the technology incorrectly. Organisational factors included culture, so things like psychological safety and safety culture as well, and the passing down of information. External factors, again, availability was mentioned, collaboration and things like data sharing between different organisations. So for example, a telephone triage organisation and like an ambulance trust, and hospitals and GPs, that type of thing. Lots again about person factors, specifically the patient, and not very much about the internal environment. So in terms of what this adds, it was the first that I know of macroergonomics approach to understanding telephone triage safety. So as I mentioned, with a limited basis to start from, not very much literature, it was really important to do a kind of exploratory study and work out, well, what are the potential areas for further research? So like it provides a foundation for future research at the micro and the meso level. So this includes obviously the physical environment. So it was still quite unclear about the physical call center environment and whether or not that could have some effects on on performance and on safety for patients. There's a little bit came out of the interviews, such as distractions and having the equipment around you, but I think this would actually merit further experimental designs, that type of thing. There are very system-specific risks identified which may differ to face-to-face care. So as I mentioned briefly at the start, some of these contributory factors frameworks that we have are developed with face-to-face care in mind, which is very different here. I think it was really useful to learn about the methods as well, to make a case for using macroergonomic analysis and design, which seems to have fallen off the radar, and to address some of those biases in technology design and evaluation. So that's all from me. Thank you very much. If you want to get in touch, I've got my link tree there, and if you have any questions, I'll take those now.
Super. Thank you very much, Jill. A very interesting presentation. I'm going to open up the floor to questions from the attendees. To get us started, though, the role of the patient has moved from a very passive participation to being a lot more active, an acknowledgement that they should take a more active role in healthcare in their own journey. I was wondering if your results, because I can imagine, especially with telephone triage, their role is very important because of that physical barrier, if there was any implications from your research for enhancing the patient role.
Yeah, definitely. I mean, I think there needs to be a massive education piece as well. I think an area that is particularly interesting to me is the idea of like distributed situation awareness. So we always talk about situation awareness, but we've also got this situation awareness between the health advisors or the clinical advisors and the technology that they're using, but also the patient and the patient's home environment and their perspective of the situation. They can be very, very different. So I think there's a big piece of work on kind of maybe even patients understanding what the other side of the triage system looks like, and what they need to do, because certainly things like presenting too many problems at once, sometimes that is relevant, sometimes things are less relevant. And I think as well, things like even the patient's home environment and things like transport, can they, if they can't get an ambulance, can they get themselves to hospital? There's a big piece on communication and education, I feel. I think that is relevant to probably all healthcare these days, but definitely with remote care, it's something that designers of these systems should bear in mind.
Super, thank you. And you mentioned the workarounds component of your research. Have you used this information to make any recommendations, or how has that been fed back to sort of support system redesign?
Yeah, so it was really great that we were able to have a clinician actually do the observations with us. So as well as 2 human factors practitioners and researchers, we had actually a clinician from the organisation, and we actually found obviously the organisational components, like I mentioned, I used SEEPs and looked at not just the workaround, but why does this happen, and is it internally, is it externally? But we were able to change things like, the amount of time that health advisors get to write up their notes, because sometimes the next call would come on and they're not actually ready. They haven't finished with the paperwork from the last one. So it has led to really practical change, and I'm sure it still will in the months to come.
Super. Thank you very much. That actually covered the next question, which was on has this resulted in any change in processes or work structure? Are there any other examples you'd like to share?
Yeah.
Like, were you able to change the software to make it more user-friendly?
So some of the software is standardized, but I think there is a lot of scope to change the software. So things like the list we found, lots of kind of colors and things that we might describe as like a risk of alert fatigue, for example. And I think there's a lot of scope to kind of change the front end and the back end of the software. Some of it is pretty standard and it just has to be used, but I think we're hoping to maybe make some changes to that, and I think there are definitely areas. I think the one really useful thing about the heuristic evaluation especially was the whole method asks you to prioritize things by severity. So I think there are clear priorities now for what might benefit from being changed. And the workarounds, certainly things that are a bit more organizational, like I mentioned, the kind of time to wrap up notes, that type of thing. And things like, I guess, a lack of standardization between, depending on who taught you how to use the system. Some people might, say, oh, type this way in this box, and other people might say, use capitals so that the clinicians can see it clearly. So I think there's certainly more awareness of the standardization to make those stand out. And I think greater access to some of the SOPs as well was brought in. So there was some, we found some sort of heuristic violations relating to consistency, as well as like help and documentation. So they could certainly make the help and documentation that they needed more salient, and they have done that and directed people to that. So yeah, there have been quite a few changes, and I hope certainly more.
Super, great. Thank you very much. Thank you again for presenting. And now we have our last presenter for today, Ali Akbari. He is a registered nurse and a critical care specialist with a critical care specialist practice qualification and an MSc Honours in Advanced Health and Professional Practice. He is now a perioperative practitioner and works as a senior lecturer and practitioner at De Montfort University, Leicester. Welcome, Ali, and I'll hand over to you.
All right, thank you very much, Evie. I'm very happy to be here, and thank you for the presentation. This research finding I'm going to present to you is very personal to me, because I'm still a practitioner. I still work in theatre, and I teach with I teach surgical first assistant. I work with surgical first assistants, and I'm still basically much part of the team. So I will part of the session today. I will demonstrate how I got my findings and what methods I use, and what really happened in between. So this research started about 4 years ago, when COVID was still a thing, and it was very difficult for surgery, and surgical first assistant became a very important personnel within the surgical field, although they were always important before. But post-COVID, because of so many problems, it was quite difficult to get many surgeries to go ahead, and first assistants were crucial into getting surgery started again, especially within private independent sectors. So what are first assistants, and who are they? They are one of the most common personnel within the surgical fields. So they started to be part of theaters many years ago without any training. They were just trained by the surgeon to do certain skills, and in 2018. We had a national recommendation which stipulates what they can do and how they can do that. So they were not registered at that point, but there was a national consensus that anybody who wants to become a surgical first assistant needs to have a higher education training and work under direct supervision of the surgeon, obviously for safety and for all the other problems that could occur within theatre. So within theatre itself, we've got many other non-medical practitioners such as SCPs, surgical assistant, physician assistant, etc. But surgical first assistant is one of the most common personnel assisting surgeons. So just if we have any international audience today, so sometimes they are also known as surgical technicians in other countries, but in the UK they are called surgical first assistant. So just a little bit about the background of the research itself. As I said, I've got a very personal interest in surgical first assistant, because I train them, I teach them, I work with them, and I'm part of the theatre team. But also a very pertinent thing we all say in practice, and we all say within the academic sort of literature, that surgical first assistant are very important, but yet there are very few papers that has been written about SFAs. There's been no research in the UK on SFAs. There's been no research on SFAs, and human factors. And in fact, there are no books written on SFAs, for SFAs, etc. So there is a huge gap, and I think I was in a very fortunate position to bring my two passions together. So surgical first assistant and also human factors, patient safety. I'm a novice researcher, and I'm a novice human factor person. I don't have a doctorate in human factors. I'm just driven by my passion explicitly. So why the need to do this particular research? So as you probably have seen in newspapers and news, there is constantly a health crisis. We're always short of staff. In the UK now, we are waiting longer for surgery. The latest data is we have 7.4 million people waiting on the surgical waiting list. And if you look at CORES, which is a confidential reporting system for surgery, where surgeons report incidences that has happened in theater anonymously, it's incredible the amount of incidences that are happening regularly and are similar as well. So they're quite similar. So it looks like and it feels like, oh, we're not learning much. Nothing much is improving. Although there are so much discussion and training and learning on human factors within healthcare, but in certain when we look under the surface, it looks like things are not progressing as it should be. And of course, we have doctors strike as well, which does not help. Just some other data from NHS England. So we almost have every year between 300 to 400 never events. And again, if you look at when the data started, even before 2015, it remained constantly the same. It didn't change. So again, it was an indication like, okay, what is going on? And from my perspective, I wanted to know whether surgical first assistant can help patient safety and whether human factors can propel them to make surgery a safer place. So I started exploring the data. So before I explore the data, so I've already said that there was not much literature, so I almost had to start from scratch. So I started with an exploratory sort of approach. I wanted to know. So I wanted the questions that we had at the beginning was rather open-ended. So what do SFAs know, and do they know about human factors, and what impact has human factors has on their performance and on patients' safety. So that was the premise where we originally started. And as a novice researcher, I was quite naive. I thought, it's going to be great. I'm going to develop so many things, a non-technical skills taxonomy for them as well. But it didn't work out this way. So as soon as I started to collect the first data, it was very apparent that there is a big knowledge and a huge knowledge gap in regards to human factors, in regards to verbalizing human factors and how they use human factors within their work, and how human factors help them, and how the performance of the surgery itself. So I will talk a little bit more about that, but I managed to get 15 SFAs to speak to me, and they were from all over the country, from down south to right up into Scotland. So the geographical area was quite varied. So they were not from one or two main hospital organizations. So there were quite a lot. I don't have anybody from Wales and Northern Ireland, but we had a huge amount of when I say huge, about 45% of people from the NHS, and the rest were from private healthcare. So I use a semi-structured interviews to speak with them and to see what do they know, understand about human factors. And the language I used was deliberately sort of patient safety too, and it wasn't about asking them, what goes wrong and what do you do about it. So it was mostly about like a learning process. And I use an inductive. So I really wanted to know from their perspectives after the first analysis of those data, did they really understand? What do they really know? And what are their impression of human factors and non-technical skills? How do they use them? How do they put it into practice, and how does it affect their performance itself? So we decided, after consultation with my supervisors, we decided to do a reflective thematic analysis, which was very helpful because PSurf came, and I was more or less directed to say, okay, this is a right approach to do. It is interviews, and we should be able to use thematic analysis and get to the answers we were sort of hoping to get. So biographical data, um, they have a huge sort of experience of those who participated. But what I want to demonstrate here is that SFAs are everywhere, and they are in all fields, and they are part of all types of surgeries, from minor, intermediate, and also complex. But what was really interesting, only one of those people were employed purely as an SFA, and that has an impact on their role. So what did the finding demonstrated? So I've classified it into three main type of categories. So we have human factors, and it was evident from the original data that this was going to happen. So right in the middle of it, it became more than only SFAs. It became about, okay, what is happening within theaters, and we managed to classify the themes into three main categories. So human factors itself, organizations, and people. And here I'm just going for the purpose of this presentation, just to break down a few things. I won't be able to go through everything and all the findings, but just to gives you like a flavor of what's really happening in practice. So first, SFAs and also other theatre staff don't feel that they know enough about human factors, and that's what they told us. Communication is a big part of the SFA's role. It's part of their job description, but they told me that it's something that are not discussed, that are not talked about. And one of the participants in frustration told me that it's communication is our Bruno. We don't talk about it. Yeah, and I can give you another example where communication failed, but then nothing happens. So, for example, a surgeon asked a heavy lane, yeah, and they went and got somebody called Elaine, who was a registrar. They laugh and talk about it, but no I'm not saying necessarily an investigation should be done, but there was nobody tried to understand what really happened here. How did we misinterpret that? So communication issues are not discussed. People are saying we're always assuming in the operating theaters almost all the times. Although there are many barriers, but there are many non-technical skills that are affected in regards to communication itself. System thinking is not necessarily always being thought about. It's always very linear, and it's always very disconnected. So, for example, this came from the eighth participant, and she gave me a very specific sort of scenario. They changed theaters. A theater was moved. It wasn't tested. It wasn't checked. It wasn't simulated, and their very first patient had a huge delay getting to theater because of that, and unfortunately, the patient died. So obviously, stress has been a huge problem, and this is one of the biggest theme: culture in the workplace, and also we learn a lot about the role of the SFA itself. So of course, they are proud of their role, but they have a lot of fear about their roles, because they have to work around all the time. And there is something called dual roles, where they are not allowed to do two things at the same time or think about two things at the same time, which also very human factors led. And they are told to do it time and time and time again. And I wanted to put all of those implications onto the SIPes and demonstrate how they are interrelated with each other. Not only to say, okay, these are the problems, but I also wanted to say how they are linked and how we have to look at the whole system to be able to help the SFAs to be able to do their role, and also inadvertently is going to help the whole theatre team itself. I don't expect you to read all of that, and I know it is quite messy, but in reality, what I found out from this research, it is really, really dirty and messy, and this is a problem we have. It's not one thing, and it's not going to fix. It's not going to be one solution itself. It demands a lot of solution, and of course, I've been able to demonstrate whether clusters are where it's impacting their roles and their performance and the way they work specifically. And finally, going forward, what do we do with all that information and with all the findings that we have found? So there are some quick wins. So one of them is about communication, and we are in some centers we are trialing those see-through face masks. So hopefully it's going to improve communication, so we don't bring somebody when they are not needed or get the wrong thing. And of course, full implementation of NATSI, but I've realized people need support. Just by saying they need to do it, it's not going to happen. They need support and they need training. And I also believe that they need to be part of the practitioners' intraoperative non-technical skills training that is provided by the Royal College of Surgeons. There is no reason why they can't be part of it, because they are working directly under the surgical influence. And they have to be partly managed by the surgeon, because again, communication doesn't really happen. It's like, oh, I need an assistant today, and of course we will get somebody, and it doesn't work. Medium solutions, although PSURF is now mandatory, there is still a lack of knowledge, a lack of understanding. People are still using root cause analysis and team training. And finally, I know I've run out of time, long-term solutions, SFA needs to be registered by their professional body. At the moment, they are not, and that's why they are being used the way that people see fit. And we need to have a national curriculum for SFAs where human factors should be part of a mandatory topic that they have to do. So thank you very much. Sorry, I've taken 1 extra minute longer. But I had so much to say, unfortunately. But thank you very much for your time and your attention.
No problem. Thank you very much, Ali. It was a very interesting presentation. I'm going to open up the floor to questions. To get us started, you talked about the surgical first assistance role. Do you know how long that's been within the NHS? Because new roles emerge, and that has an impact.
Yeah, it's been around for a long time. I know from 20 years ago, we already had them. They were called by a different name, though, advanced perioperative practitioners. And some of them were trained in-house, so there was no specific curriculum. As I said in the presentations, a surgeon trained them and said, I need an assistant, so I will train you to do certain things. And then in 2012, it was more or less loosely regulated by the PCC 2012, but again, there was no specific curriculum of what they specifically had to do. But in 2018 is when it was quite firmed up, and this is when it was stipulated that they had to have higher education training, and they have to work under the direct supervision of the surgeon, and there are only specific things that they can do.
And associated with that, because as names change and the roles, and it becomes more formalized, is their role clearly defined, or as the role has evolved over time? That because you mentioned the strong identity of the group. I can imagine that the roles and responsibilities and how those are viewed by their teammates is quite important in the medical team.
Yeah, There is a Royal College of Surgeons 2021, I believe it is in my reference list, where there is a framework. There is a specific job description of what those SFA can specifically do and can't do. But unfortunately, that's why I said there is a lot of work around in practice. So, for example, I can give you a very specific example. On a Sunday afternoon at a private hospital, where there is only one surgeon and one SFA, and they're doing a lap chole and the patient bleeds. You as an SFA is my only help. There is nobody else in the hospital who can come and help me. And that's the problem. So risks are being taken, and that's because of the organizational push to get lists down, to do more surgeries, and we're doing more with less, and we are basically working around rules and regulations.
I mean, the example you just gave highlights two SEEPs outcomes. One is the risk
Yes.
to the patient, because
Yes.
it's not supposed to be done that, but it
Sure.
also has an important implication for staff well-being. If you're
Yep.
doing work that you feel is not part of your job or is risky, that can have quite negative implications for that staff group.
Yes, absolutely. And in terms of surgical first assistant, there's something that they have to do, which is called self-care. So in between cases, they are supposed to rest, and they are supposed to take their health, hungry, angry, and everything break, and they are supposed to be able to rehearse the next surgery, and they can't do that because they are being asked by their peers, by the other peers. So can you come and help us and get the trays ready, get theater organized, and that's encroaching on their role, and that's preventing them doing functioning properly, being part of the surgical team, and the surgeon are not standing up for them. The surgeon, or I am generalizing, but I've only have a sample of 15. So the surgeon go in and out, and then they just want their surgical first assistant ready, and they don't necessarily want to know what has happened in between.
The system needs to actually be designed to support staff being able to look after their well-being, especially when it's mandated as part of their role.
Yeah, absolutely. And I try to demonstrate that on that SEEPs analysis, because it's all interrelated.
Thank you. And then one final question. You mentioned some practical recommendations. Do you have any evaluation plans to sort of see how they're going? Like, for example, the clear face masks,
Yes.
or items like that?
Yes, I have a couple of hospitals who are planning to trial the face mask to see whether this will improve communication, especially when it comes to patients. So they do a lot of local cases where they have to speak to patients to keep them comfortable in everything. Yes, that will be evaluated as well. And I'm also in conversation with not many, but a couple of hospitals. They are interested on how they can improve safety through this particular research and what we have found, but also quality of care and the teamwork and support and everything.
Super. Great. Thank you very much. Thank you for a
you.
very interesting presentation. So we have come to the end of our session today. I'd like to take the opportunity to thank all the presenters again for some very interesting presentations and some very interesting questions. Thank you to all the attendees for joining us. Can I just call all the presenters back on screen for one final goodbye? Yes, thank you to all the presenters. Thank you to all the attendees. As I mentioned earlier, this is the first in a series of 5. Our next one is scheduled at the beginning of December, so please be on the lookout for that advert, which will be going out shortly. And thank you to everyone today, and have a good afternoon.
Thank you.
Thank you.